What's going on, everyone? Thanks for showing up to the movement-based podcast. This is episode 2, and today we are going to talk about all things hips. So for those of you, if this is your first time showing up, first time listening, this is the movement-based podcast. I'm your host, Sheldon. I'm a sports medicine specialist. I've been an athletic trainer for a little over 5 years. I've been in the health, fitness, and wellness industry for a little over 2 decades. I've had experience working in the private sector, working in collegiate athletics, high school athletics, working in a tactical setting, as well as safety and ergonomics. And this is my medium to share perspective and insights on various different things when it comes to orthopedic sport injury, when it comes to fitness, when it comes to health, sport nutrition, anything in between when it comes to those topics. This is the whole purpose and intention with this platform, with me creating this podcast. So this is episode 2. We're going to be talking about hips. And in episode 1, we started talking about the back. We started talking about contributing factors to low back pain, a few of the culprits being posture, being inefficient movement patterns, overstraining, right? So inefficient lifting technique as well as breathing mechanics, right? Because we know that the deep core, right? Most people, when they think core, they think six pack. This is not what we're talking about. That is going to be superficial core. That is societal core, not what we're talking about. That is going to be superficial core. That is societal core. Hardcore societal core. This is talking about your deep core stabilizers. I like to call this your trunk, right? So we're talking about the diaphragm. We're talking about pelvic floor. We're talking about multifidi. Those specific structures are what I refer to when I say deep core stabilizing system, right? So your diaphragm is essentially a balloon-like muscle that attaches to your rib cage. Your pelvic floor, in essence, is essentially a balloon-like muscle that attaches to your sacrum and your pelvis. These two structures need to be in congruent alignment with one another because when they're out of alignment, that's when we start running into issues like discogenic type symptomology, right? So if we have some sort of nerve compression, if we have a disc issue, if we have allergy, right? So if we have some sort of nerve compression, if we have a disc issue, if we don't have optimal congruency and alignment with all the structures, all the joints, specifically, we're talking about here the pelvic floor in alignment with the diaphragm. You want to, excuse me, you want to have to, because essentially this is going to optimize true trunk stabilization. When we talk about the cylindrical like system of our torso, right? So when we have these two alignments of the diaphragm, of the pelvic floor, we can breathe more fluid, right? So we can take a fuller breath. 2, we're not running into, increased risk when it comes to injury of low back. Because if we don't have an optimal alignment, essentially we can refer to something known as an open scissors pattern posture, or essentially your rib cage is bucked up, right? Your hips are dumped forward, right? This is most seen and common in the wild of society. Something I like to refer to as twerker butt, right? Where people just have their butt stuck out for whatever reason. But this is a postural abnormality. This is not good. This creates excessive discal compression, specifically on your low back. Because essentially, if you look at that person from the side, you're going to see their rib cage flared up. You're going to see their hips flared down. And it's going to be a convergence of an open scissors, right? Where the convergence point is going to be on that low back. So more oftentimes than not, those type of people, right, that walk around in that posture, whether it's voluntary or involuntary, are going to always complain about their low back, about their back being so tight, about them, they probably do a ton of stretching and it doesn't really have an effect or assist or help with their symptoms because the posture is what needs to be corrected, right? So what people think about when they stretch, they think, oh, well, I'm stretching out the muscle. The muscle can now relax. Sure, it can relax for a little while, But if you're patterned and you're conditioned to this, let's refer to it as open scissors, right? If you're patterned and conditioned to this open scissors posture, doesn't matter how long you stretch, you're going to revert back to that posture, back to that pattern, right? And then it's going to be tight all over again. So it's a circular type of I wouldn't even call it treatment. It's a circular type of mindset where, oh, I'm in this bad posture. Let me work on stretching the muscle. Let me work on my workout. So let me look really good for Poppy, right? But then the low back is still pissed. It's not helping, right? So we got to understand these concepts. We got to know these principles, right? And the more we can better ingrain this into whether we're treating in the clinic, whether we're treating on ourselves, whether we want to have a better understanding of our body awareness, spatial awareness, being proprioception, any of that stuff. These concepts are going to be foundational because this is what we move upon. The vestibule of this body, of this human meat suit that we have and possess. We got to take care of it. So we got to know how to move. So went down a little bit of a rabbit hole there, but we are still, I promise you, we're still talking about the hips. So I'm going to go start off here with some entry level points here. So again, thank you all for coming back. If you all have listened to episode 1, I have it posted on the YouTube. I also have it in my free school community that you're welcome to join. School.com/movement-based therapy. A little shameless plug there. But with that, I wanted to start off with an entry question here. And that question is, what if your back pain isn't coming from your back at all? And there are going to be philosophies and schools of thought and specific treatment principles that are in alignment with stating that all pain centralizes to the spine, to the center spine, right? To the central spine, whether it's neck from the upper extremity or whether it's the lumbar spine from the lower extremity, all the pain comes from the central spine. And if you think about it like that, sure, it does make sense because the nerves, the nerve roots come off of the spine, right? And the nerve is essentially going to be that software integration into hardware. I use this analogy because, right, the nervous system is an electrical conduit for the brain to integrate the systems of the body, right? So in the instance of me putting my hand on a hot stove, I'm going to immediately react and recoil my hand back. Reason being is because when my hand approaches that stove, I get the input of the heat on my hand, right? The nerves are stimulated. That information is transferred from the nerves via afferent, no, it said MADSEV, motor afferent dorsal, sensory efferent ventral, right? So it's a little acronym that I remember, MADSEV. If you're trying to remember motor or sensory, right? If you're studying for an exam in ortho, MADSEV, remember those acronyms. I got a bunch of them, right? But MADSEV, motor afferent ventral, this means motor output, right? So when I contract my muscle, my brain is telling my muscle to contract. That is motor, right? That is motor output. If I got to do a task, right? If I got to do something, the brain is organizing, synthesizing the information, and then it's creating an output. The output is motor, right? So that is going to be ventral. That is mad afferent. Afferent. I'm like studying along with this episode here. It's great. And then you have sensory, right? Sensory, efferent, sensory efferent ventral, right? So ventral, and we have the dorsal horns of the spine. Sensory efferent ventral is how we get this information, right? So it comes up ventrally through the sensory. So our hand goes on the stove, we feel the heat, we want to recoil it away. Before we do, that information gets processed and synthesized via our nervous system to our brain. Our brain then processes this information in a matter of milliseconds, and then we recoil our hand away. That is the motor output. So this is essentially how our nervous system interprets and analyzes information. So we got to understand this because now we go back to, hey, what if your pain isn't truly coming from your back? It's coming from your hip. Well, that's an interesting thought in theory. And we're going off of treating the spine and all pain coming from the central spine. So if we understand this concept and say, well, the nerve root comes off the spine, and if the nerve root's irritated, it's going to have an affect on the systems downstream, right? So in the instance of let's just say L3, right? My third disc in my lumbar has a little bit of inflammation and irritation, right? And now I'm going to have an affect on all those muscles that are innervated by my third lumbar, right? So my thigh, my inner thigh, my adductor muscle, right? That is going to, maybe I might feel some numbness and tingling on my inner thigh, right? Maybe I feel some numbness and tingling on my hamstring, right? The philosophy and the school of thought based off of saying that, hey, all pain centralizes to the spine, back to the spine, would say that, oh, you have numbness and tingling in your thigh and in the back of your hamstring. Let's look at your low back. Let's do some repeated motions. Let's see if we can have a reduction in symptomology. Time and time again, I have used these principles and have had clinical success and outcomes, right? But this question here that we're posing is, what if it's to say that your pain isn't actually coming from your low back, it's coming from another structure? And this is where we look at now, like the kinetic chain, and integrate the systems up and downstream. So if we're talking about low back pain and we're saying that the low back pain isn't actually stemming from your back, it's rooting from somewhere else, what could be the other structures? Well, now we go upstream and we go downstream. And if we go upstream, we can say that, okay, well, what's upstream from the lumbar? Your thoracic, right? So your thoracic spine, your T-spine, your rib cage, right? You have vital organs, you have muscles and you have structures, but you have muscles rather. I say muscles being the soft tissue, structures being the hard, rigid tissue, your bones, the things that are not going to break, or if they do break, you're in trouble, right? So your bones, we'll call it that. So one level above your lumbar will be your T-spine, will be your rib cage, right? And then we go below. What do we got below? We got your hips, we got your pelvis, we got your sacrum, we got your hips, right? Your hips being your femoral acetabular joint. Just like your shoulder, they're both ball and socket joints. So your hip joints are very much like your shoulder joints. The only difference is one is more robust, right? Because we're taking load on it all day, whether we're seated, whether we're walking, any sort of weight bearing to the structure is going to create these sort of adaptive changes. And this is how we've evolved over time because we are bipedal, being that we walk on two legs. Sorry, I'm observing my surroundings while I'm dispensing this information here. We walk on our two legs. So because of that, our hips have to be able to absorb load. And we don't want shallow sockets in our hips because if we do, we have an increased likelihood and chance of dislocating. So that's not a good thing. So we need to have robust hips. Of course, there can be too much robustness. There can be too much beef on the burger to say that we can have too deep of a hip socket where it encroaches on our kinematics, on how we move, on how we're able to move, right? And then we can also have too shallow of a socket. So it's a ball and socket joint. Either the socket can be too deep, or the ball can be too big for the socket. In both instances, this is something known as true femoral acetabular impingement, FAI. Right? People will say, oh, I got a clicking in my hip. I think I got hip impingement. No, true hip impingement is diagnosed via imaging, right? They have to get diagnostic imaging. Then they have to do the measurements and they have to say, okay, your femur, the head of your femur is oversized for your hip socket, right? This is a cam deformity, right? So a cam deformity, you have three types of hip impingement. I can't remember the three off the top of my head, but that's the beauty in this is I don't have to remember. I'm dispensing information, and we're talking about hip impingement. You got three types. One is where the socket is too big. Another is where the ball joint is too big. The third is a hybrid of the two, right? And that's going to be true hip impingement. So if you're walking around, and you're like, oh, I got like a pincer or something like that. I got tight hips. I think I got hip impingement. Okay, the only true way to diagnose hip impingement is going to be through diagnostic imaging. So all that to say for that. So what if your pain isn't coming from your back at all? Coming back to the question. So we look at the level below now, right? So if we have something like a labral tear, could it present as low back pain? Absolutely, right? And we look at the labrum. The labrum is essentially that cartilaginous shock absorber. Like we have one between our knees. The one between our knees is known as our menisci, right? We got two. They're called meniscus, right? We got one menisci. In our hip, we have a labrum. A labrum is that connective tissue shock absorber, right? Very cartilaginous, avascular as well. So does not have good blood flow. So if you tear it, the likelihood of it healing on its own, highly unlikely. More than likely, you'll continue to have symptoms, and the symptoms may progressively get worse because you're always bearing weight on your hips, right? More wear and tear on a already piece of cartilage that has sort of a lack of integrity now because there is a tear in it. It's going to deteriorate faster because of that, right? So just bear that in mind. So, could the structure of the hip have an effect on the low back? Absolutely. And because they're structures next to each other, this can absolutely be a thing. So, pardon me, by the way, I want to infer here that there's a lot of like going back and forth when I talk. This is me jostling the ideas in my mind. This is me trying to synthesize the information. And I might say something one way and I'll say the exact same thing another way. I'm catching on to this. I get it. I know it's a bit of a process for me to explain this, but I appreciate you all bearing with me here to get this information out. So now we're going to talk about understanding the hip and spine connection. I got a little bit of a script here so I don't go too far down a rabbit hole and not be able to come out because I don't even know where I'm at. So we're moving on to the first segment here, understanding the hip and spine connection. So basic anatomy. We've already talked about the anatomy, right? We have the femur, right? The proximal end of the femur is going to be a ball, right? And then we have the hip socket, right? The ball and socket joint. We have two ball and socket joints in our body, one being our shoulder, the other being our hips. So in between the ball and socket joint, like I mentioned, we have the labrum. That's that cartilaginous piece of tissue. In between the ball and socket joint, like I mentioned, we have the labrum. That's that cartilaginous piece of tissue. It's a vast more stability, our hip, or one is going to buy us more mobility, our shoulder. Right? So you can think of the shoulder as a ball and socket joint, a lot less cumbersome. It's more or less like a golf ball on a tee. It's kind of how the shoulder is best articulated, a lot less shallow with the expense of less stability, but at the advantage of having more mobility. So good to know, good advantage of having more mobility. So limited hip mobility. How limited hip mobility transfers load and stress to the lumbar spine, right? So there's this concept known as regional interdependence, which states that, one pain or symptom can be the root cause of a pain or symptom can actually states that, one pain or symptom can be the root cause of a pain or symptom can actually be stemming from the unrelated structure. So in the root cause of a pain or symptom can actually be stemming from the unrelated structure. So in the instance of an oblique fascial line, right? I can have pain in my left lat. The root cause of it could be coming from my right plantar fascia. So that's actually where the root cause of the pain is, but I feel the symptom of pain and discomfort in my left lat, right? This is that oblique sling connected by fascia. In that same sense, right? We can have hip pain or we can have a lack of hip mobility have an affect on our lumbar spine. Because if we take a joint by joint approach, right, we have joints that are basically staggered in a fashion of mobility and stability. In the instance of our ankle is mobile. In the instance of our ankle is mobile. Our knee is relatively stable, right? Doesn't can move in any which direction. Our knee is like a pseudo hinge, right? Can move in any which direction. Our knee is like a pseudo hinge joint, right? Because we can flex and extend, but our tib-fib joint can internally and rotate along the tibia, among the femur, right? So we have sort of like I call it a pseudo hinge joint, because most people will think of it as a true hinge joint because it can flex and extend only, right? But at the same time, you can also simultaneously internally and externally rotate. This is when you straighten your knee, your foot is going to turn out. When you bend your knee, your foot is on tib, fib, flexion, and extension, right? So all the flexion and extension, right? So all that to say pseudo hinge joint. So when we look at the hip has many different degrees of freedom, right? Like our shoulder, right? So it's a mobile joint, right? And again, we go back down to the mobility, stability. So we go to the ankle is mobile. The knee is stable. The hip is mobile. The lumbar spine, right? That'd be the next joint up, is stable, right? We need stability in our lumbar. If we have too much mobility in our lumbar, then we pop a disc or we run into low back issues. That can be pathoanatomical, right? Pathoanatomical, pathoanatomical simply meaning that a structure is now under a disposition of injury, right? Oh, you have a low back strain, right? The anatomy of it is, could be your paraspinals, could be your QL, um, could be your deep core, right? Maybe it's not coordinated optimally. So all this to say, it could be pathanatomical, and if we have too much mobility in our lumbar spine, that's when we run into issues because now our lumbar spine is mobile. What will happen is the joints will flip, right? So then your hips will start to stiffen. So now you have stable hips when you should have mobile hips, and then it streams up to your lumbar spine. Now you have a mobile lumbar spine when it should be a stable lumbar spine. Now your thoracic spine is stable where it should be mobile. We rotate almost exclusively through our T-spine. Majority of our rotation comes from our T-spine. Now we're locked up. Our breathing's all jacked up because our lungs are within our rib cage, which are attached to our thoracic spine, right? It's a whole cascade of events. So if the joints become inverse, right? Now I have stiff ankles. Now I'm going to have knee issues. Now I'm going to have hip issues, right? This is the idea of regional interdependence, right? So we can have an affect of joints. We can have an affect on the fascial system. We can have an affect on the musculoskeletal system, which is essentially housed by the fascial system, right? So we got to understand these concepts and principles if we're trying to get the most out of whether it's human performance or even out of our own rehab plan. So kinetic chain, this is the perfect segue, and I've kind of touched upon that with what we talked about just a few minutes ago here. But the kinetic chain where everything is connected, right? So your hips set the stage for how your spine moves. I would take that almost a level deeper and say that how we connect to Earth, is going to dictate how we move, right? So what is the initial contact with our foot? Are we heel striking? Are we over supinating or are we over pronating? Right? Do we have a good foot stabilization strategy when we make ground contact? When we're trying to produce force, do we have a good strategy for force production? Are all the systems working in a coordinated fashion? Are the nerves firing in right sequenced order? Are the muscles operating in the right order, right? Am I hip hinging? Are my knees bending? Am I propulsing and driving through the big toe? All of these things have to happen in a coordinated manner. And if they don't, right, you can sort of think of it like a motor, right? If a motor is firing, if the cylinders are off when they're firing, right, it throws everything off, right? Now the sequencing is off. Now the coding is off, right? And you got to look down the road. I'm not a mechanic, right? But I'm just saying from a very loosely based understanding of motors and cylinders and hearing it over and over again in my lifetime. Oh, the cylinders are misfiring and it becomes a whole issue. Very much so how our body works, right? If the body isn't working in a coordinated fashion because maybe the nervous system isn't right, isn't prepped, isn't trained, maybe the muscles aren't trained, right? Maybe it's the speed hasn't been trained. All of these it's multifactorial, right? If these systems aren't trained in sequence in the right order and fashion, we can run into issues. We can run into injuries, increases likelihood for sure, right? And when you see these athletes just doing things that are like, oh man, they just make it look so easy. Well, yeah, they've been trained, they've been prepped, they're conditioned. That's their forte, that's their career, right? That's what they do for a living. They're athletes. So it would behoove them not to not be athletes. So all this to say is that how we connect with Earth is going to completely have an effect on the entire kinetic chain, right? The kinetic chain being the whole system that we have here, this whole body system, right? From skeleton all the way to fascia, all the way down to vital organs. They all work in a harmony to contribute to what the end goal we are trying to accomplish is. So the better we can understand that everything's all interconnected, the better we can manage these systems, the better we can have a more broad lens when it comes to evaluating an injury or when it comes to understanding something we're working through or even something that you see. You know, you're playing on a club soccer team and your teammate rolls their ankle hey, you have an understanding of saying, oh, wow, you rolled your ankle. Well, yeah, I was just watching you kick the ball there and it just didn't seem like you were planted right, or it seemed like you were rushed, or it seemed like you were doing something that you weren't quite ready for. So, all of this to say that interconnection of the body is the kinetic chain. All the systems work in a synchronized harmony. And the better we can understand that, the better we can have our broad lens to be able to evaluate and create more perspective from. So we're talking about why our hips are so tight. Why are our hips so tight? Why are my hips so tight? Talking about modern lifestyle, right? Modern lifestyle, societal factors, things that we've been told we need to do. We need to work a job. We need to sit for a long period of time. We need to always bend forward. They're working an 8, 10, 12-hour job. If it's a labor-intensive job, even they're taking even more of a toll on their body, right? And in these instances of heavy laborious and manual work, there's a lot of repeated motions, right? So it's like, oh, it's good for them. They're getting the motion lotion. They're doing it, right? Oh, to an extent, but also you can abuse a movement pattern where you're doing it way too much. And that's the whole idea and concept of repeated motion. If we're moving too much, if we're moving one way too often and not giving balance in all the other ways we're meant to move, we can stiffen up and we can create our own sort of discomfort, pain, pathology, because of how we're meant to move, right? So if we're always bending forward, whether it's ski, whether it's working out in the gym, whatever the case might be, if we're always bending forward, we need to make sure that we create spine because we're bending forward, it can bend forward, right? But it can also bend backwards. So we can bend backwards. It's primarily responsible, keyword primarily responsible for rotation, but we also get a little segmental rotate through our lumbar spine, as well as side bending. We can side bend through our lumbar spine. So we got to make sure we're incorporating all of these movements and we're not overindulging in one movement pattern. We need symmetry in our movements and how we move. But back to the lifestyle factors, right? So working a long job, working heavy manual jobs, right? Repeated motion is a thing. Or if you're prolonged sitting, right? You're sitting for a prolonged period of time, whether it's at a desk, whether you're doing it for you to sit for a long period of time. What a time to be alive, because we have what's known as a standing desk where you can sit and you can stand. And there's going to be some people that say, well, you know, whether you can't afford a standing desk or you don't have access to getting a standing desk, that's okay because you can still stand every so often. And I like to incorporate what I call micro breaks. I use the 1-2 mantra, right? The 1-2 mantra pretty much states every 1 to 2 hours, you're getting 1 to 2 minutes of meaningful movement, right? I say meaningful with an emphasis, movement, right? The emphasis is on meaningful, right? Because people are, especially the heavy labor workers, right? I work in a safety and ergonomic setting right now. And I have people, I tell this to them and they give me a side eye and say, Sheldon, I'm moving around all day. I don't know what the hell you're talking about with this movement stuff. I'm like, no, you're not listening here. I'm saying meaningful movement, right? What are you doing all day? I'm like, well, I'm doing this. Okay, well, have you observed? Have you kind of created an awareness of what that movement looks like for you on the daily? Like, if you had to break it down, what is the movement that you're doing? Well, I'm bending forward. Okay, how often are you bending forward? All day, man. I do this all day. It's my job. Okay. Well, meaningful movement for you could simply mean doing some back bends, right? How about you do 10 back bends every 1 to 2 hours? Keep you even keel, right? Keep you maintained. I call it a soft reset, a nice little spinal reset there. After bending, after doing hours and hours of bending forward, do yourself a favor and do some back bends, all right? Trust me on this. And they do it, sure as show, their low back pain starts to abolish, right? They start to have a decreased symptom of low back pain or discomfort, and they're able to continue doing one, their job, and two, what they love doing, which is what they're doing outside of their job, right? A job is just a means to an end so that they can provide for their lifestyle, right? The lifestyle is the true purpose and the true why, whether it's spending time with family, whether it's being able to, pick up your kid, whether it's, a sporting event or activity or club that you're a part of, whatever the reason, whatever your why is the reason why I is the reason why I'm in my position where I'm at my job, right? I mean, it's not directly why I'm there, but I've ingrained it into my purpose and my foundation, with good faith, right? To say that, hey, the doctor might have told you this, that, and the other, right? I would recommend you get a second opinion, or let's take a look at what's going on. I would hate to send you to the ER where they just give you pain meds and tell you to rest for a week, when really what we should be doing is introducing education and restorative movement that's going to actually get you feeling better and keep you moving, because we're meant to move. We're not meant to stagnate and stay still and pop pain pills for weeks on end. That is a deep, dark rabbit hole. And most people aren't for that anyway. So I'm very thankful to be able to provide the services that I do to help these people to continue to be able to do their job, provide for their families, as well as allow them and give them more of a reason to continue doing what they love. Because quite often I come and give them more of a reason to continue doing what they love. Because quite often I get people that get low back things. They come in and see me like, oh my God, more of a reason to continue doing what they love. Quite often, it's been the case where it actually ends up worsening, right? And, disc fusions, low back surgeries, uh, more oftentimes than not, it ends up becoming a multi-segmental fusion. Because now think about it, right? The spine is meant to move. And now you have a piece of surgical stainless steel replacing essentially a disc or a transverse prosthesis or one level of your spine. You have a very rigid piece of hardware that is basically screwed in and tied into the rest of your spine. There is not synergy in that. There is not synergy in that, especially if it's a fusion. You're locking up these segments that were once mobile. Now they're stable, right? And now essentially these other segments are going to deteriorate at a more faster rate because it's going to be increased wear and tear, because it's less than optimal. It's a less than optimal movement pattern and strategy for the spine, where now it has to be strapped down via a couple stainless steel screws that were installed by a Makita wireless drill. So all this to say, avoid the surgery as much as you can. If you don't need surgery, don't get it. Fine, right? Before you get the surgery, this is me kind of digressing off of our topic of hips, right? But before you really take into consideration a surgery, surgeries are permanent. You can't go back, right? It's like getting a haircut. When you cut it, well, I mean, your hair grows back, but when you cut it, it's done, right? You can't undo cutting a piece of hair until it grows back. But with the surgery, um, like Ben Bridge says, oh no, is it Ben Bridge? I'm trying to be funny here, but surgeries are forever. You can't go back with it, right? So, all this to say, if you do end up considering going under the knife, either make sure you do your research on the surgeon, make sure you do your homework on the specialty, on the doctor, on the surgeon, um, and if you need to, don't hesitate to get a second opinion. Right? Because once it's done, it's done. There's no undoing it, especially if you're having hardware installed. Um, in the instances of pathologies that I would probably recommend going under the knife for, one of them would be something like a shoulder labrum repair. And this is my perspective right now. 5 years could go by and I could have a completely changed perspective. But as of today, July 8th, 2025, I feel that getting a surgery for a shoulder labrum, one, make sure you got a good surgeon. But all those conditions met, a shoulder labral surgery is going to have far more favorable outcomes than a non-surgical procedure that just goes conservative with physical therapy. Could you do it? Yes. Right. Just like you don't have to get the bicep reattached once you rupture it. Right. You've seen those people that pop their biceps and it goes up. I've met a couple people that's happened to them, um, and they never got the surgery. And they said, "Well, I'm doing fine. I can still push. It's not as strong as my right side. If it was their left side, it's not as strong as my right side, but I'm still able to do. I'm still able to function. Okay, sure. But we also have structures and muscles that can compensate a movement um, that can get around not having a bicep or not having a pec, right? Or not having a muscle, right? We have many muscles in the body that there are going to be compensatory muscles and movement strategies that the brain will figure out, right? The brain's really good at figuring out a way. It's not going to be ideal, but it does do that. It can't do that, right? And one thing it can't really do well is decipher the difference between hunger and thirst, right? So, kind of sidebar here. If you think you're hungry, have a few sips of water, wait a few minutes, right? And then reevaluate. Were you truly hungry or was it just thirst? So, all this to say, all this to bring us back onto our conversation of hip, of hip. So now we're moving on to the next line item here. Uh, so we talked about modern lifestyle. Why hips are so tight? Modern lifestyle, right? I think I beat that to a dead horse already. Lack of variability is the next one, right? And I kind of alluded to this a little earlier when I was talking about repeated movement strategies, right? So if we're moving one way over and over again, our hips especially aren't going to like it because our hips can move in many different directions. We can internally, externally rotate. We can internally and externally rotate at the femur. We can do it also at the tib fib, right? We can flex, we can extend, we can AB and AD duct. We can also do it in a horizontal way where we AB and AD duct, right? All of these are just different movements that we can produce at the hip. All this to say is that we have many degrees of range of motion that we can move in comparison to like a true hinge joint, which would be something like geez, I don't even know if the elbow would be a true hinge or yeah, true hinge joint because we also have the radius and ulna, which can supinate, pronate and supinate. So while I flex and extend my elbow, that's the hinge. But at the same time, I could pronate and supinate my forearm, right? Which is essentially medial lateral or internal external rotation with flexion and extension, differentiated. So all this to say is, yeah, our elbow is a pseudo hinge joint. Our knee also very same fashion, pseudo hinge joint, right? If we're talking about like a true hinge joint, right, we could probably, I don't know, I mean, flexion and extension can exclusively occur at our finger, right? But we have multiple different levels of joints. All this to say, a repeated movement, right, over a prolonged period of time, if we're just doing one movement strategy among the many different movement strategies we have access to, and we just use one, we can run into hip stiffness, right? Because essentially one movement pattern is going to be perpetuated over the other movement strategies we can also integrate. So if I'm never stepping off to the side doing the lateral movement and I'm always only doing sagittal, front back, right? I do front back and then I'll turn and then I'll go more front back. I'll never move lateral. Those lateral movement patterns will become stiff and weaken and sort of not go dormant entirely, but they just won't be as effective moving strategies because you've biased sagittal movement, which is front and back again, right? So all this to say is repeated movement, movement, one movement pattern in axis among the many different movement patterns you have access to is going to create deficiency when it comes to hip tightness, hip stiffness. An imbalance. So this is another one. The imbalance of mobility over stability or vice versa, stability over mobility, right? This is one that can be easily identified by that gymnast that you know that can, or maybe not a gymnast, someone you know that can drop into a splits. They drop into the splits and then how do they get out of it? Get out of it? They tuck and roll, right? They tuck and roll because they don't have the stability of that range of motion. So they can drop, they can drop, they can drop. Sure, they have the mobility. And remember, again, mobility is the free, unrestricted range of motion that a joint can naturally move through. All of the range of the motion a joint can naturally move through, unrestricted, right? We run into restriction, whether it's structural, whether it's muscular, right? Soft tissue. These tissues can become adhered, these tissues can become restricted. We can get trigger points. We can get stiffening or contracture of joints or soft tissue. So for the instance of someone who's in a long arm cast and their elbow's been at a 45, right? If they're in a cast for a certain period of time or a prolonged period of time, or even like a shoulder sling for a prolonged period of time, The elbow is going to stiffen up in this bent position. The shoulder is also going to stiffen up from being in the sling in just that supported position where it's not going to feel good moving around. Sort of like the case of a frozen shoulder. It's a little different there because there's other factors that come into play, but it is essentially a stiffening and contracture of the joint. So all this to say is we want to make sure that we're getting movement variety, and we're also training mobility. We're balancing as well as training, working on mobility and stability work. Mobility, the free unrestricted movement of a joint range of motion. Stability, the ability to control that range of motion. So our friend that can drop into the splits, can they get up with control? Can they utilize the muscles and coordinate those movement, coordinate those sequences so that they can get back to their return state of standing, right? Or do they drop and tuck and roll? If they drop and tuck and roll, they have mobility, they don't have stability, right? On the contrary, someone who's very stiff and rigid maybe has too much stability. So they can barely open their legs to a split stance. There's no way in hell they're going to go down towards the ground into a full split, right? They may have too much stability, right? So their muscles are too restricted. It could also be the nervous system. It also could be the brain guarding positions, right? So if we talk about injury, right, the brain has a very spot on protective mechanism where when you experience an injury, it is biopsychosocial, right? All the factors come into play. How the injury happened, who was around when the injury happened, the specific trauma of the injury of the event, right? Was there any sort of psychological factors that come into play? Of course, there's psychological factors because you have the trauma, right? But how big was the trauma? Was it like, I rolled my ankle and it just feels a little irritated, right? Now your brain is on guard. When you roll your ankle again, it's going to want to prevent you from doing that. So it'll stiffen the ankle, right? If you don't rehab it right, it'll stiffen the ankle. It'll have pain whenever you load the ankle. That's going to predispose it into rolling the way that you did, right? This is all going to be based off of the neurological, the psychological system of our brain, right? And it's protective. It's an innate protective mechanism for survival is what this is. So when we break it down, right, we got to understand when we get injured, it's biopsychosocial factor. We have to take all of these factors into consideration. Were there other parties involved? Was there a color involved that, I'm just now repelled by? These are things you have to take into consideration because long after you're done through phase 3 of healing, years past the injury, right? We all know those people that are like, yeah, I injured my back 5-10 years ago and it's never felt the same since. Well, why is that? Did you have a good rehab strategy? Are you incorporating movement variety, right? Or are you shying away from the movement that you got injured from or how you got injured? Are you no longer doing the activity that caused the trauma? Right. So there is definitely a psychological component that comes into play, right? And most specifically, if we want to break down the part of our brain, it's the motor homunculus that shapes our personality, shapes our emotions, our feelings, right? Part of our frontal lobe, how we develop our emotions, our personality, our psyche, all that. All right. Going down the list here. We are not there. Cultural differences. That's another one, right? So cultural differences can tie into why our hips are so tight, right? If certain cultures are sitting for a long period of time, some cultures sit in a kneeling position, right? Specifically, like Asian cultures, they'll sit in seiza, right? Which is essentially like a tall kneeling position where you're sitting on your ankles, right? Sitting on your ankles, you're in a lengthened plantar flex position, increases anterior lengthening of the anterior capsule of the ankle. You're in deep deflection, so you have good knee mobility, and also you're seated in an upright position. You're in partially hip flex position, so you have hip flexion. Lumbar spine is relatively upright, so there should be no load on the spine other than gravity creating other than gravity's natural compressive force. But other than that, this is an example of a culture um, that could, have maybe less of a lack of hip mobility, or maybe more of an issue of hip mobility because they're always in a hip flex position when they sit seiza. But they're not just doing that all day unless you're a Buddhist monk just meditating all day. But even then, uh, I would probably find it hard to believe a Buddhist monk has a lack of mobility because all of the other things that they do in their practice. Uh, but I continue to digress. So that is segment 2 in a nutshell. All right, why I'm so tight. So moving into segment 3, and this has been quite the episode. I am just kind of ranting on here all of the topics, but that is okay. But because now we're moving to segment 3, which is the self-assessment portion where you're going to test your hips. This is probably a segment that would be good if I could sort of demonstrate it, have some sort of visual representation, but I don't got that. All right. I don't got that right now. So we can go by explaining these different positions and provide the information such that you can utilize and do your own assessment and evaluation off of your movement quality. So, starting off with a self-assessment, the first one is going to be a seated 90-90 test, right? Seated 90-90 test. This is also known as a pigeon pose, right? So you get on the ground, you basically get in sort of a supported side sit position. You're going to put one leg up in front of you, right? Bent at a 90-90, right? So 90 degrees, 90 degrees. Mm-hmm. And then the other leg is going to be essentially going to mirror that leg in a 90-90 fashion. That is going to be what is essentially known as pigeon pose. Can you get into that position? First of all, can you get down on the ground, right? I only say that because I've worked around people that have a hard time getting up and down and off the ground. And that is that's concerning, right? If we have, someone in their 50s, 60s has a hard time getting up and down off the ground, that's a concerning because now we worry about fragility, right? And longevity, right? If you're having a hard time getting up and down off the ground, if you fall, what does that mean for you? Does that mean that you're not going to be able to get up? Does that mean now we take into consideration why are you not able to get up and down off the ground at the age of 50, right? It's relatively young to not be able to get up and down off the ground. Is there a history that I'm not aware of? Is there a condition I'm not aware of, right? Or is it just a lack of movement, right? Have you just been, have you lived a stagnant lifestyle? Right? It's kind of the question I allude to. And if that's the case, it's concerning because, we think about bone density, our bones adapt based off the load and stress they're given upon. And if there's no stress because we're living a stagnant lifestyle, our bones will become frail and that increases the likelihood of fractures, right? Now I can't get up and down off the ground. Now I fall, right? What is the likelihood of me breaking a bone? Probably highly likely if we take all these factors into consideration. So we need to know, we need to have an understanding of quality of life when it comes to this as well. So a seated 90-90. Seated 90-90 is a good first test, which is also indirectly testing your capacity to get up and down off the ground, right? If you can get to this position, are you feeling restriction? If you're feeling restriction, where are you feeling that restriction? Is it in your breath? Is it in the posture? Are you creating compensatory tension patterns, right? Like you get on the ground, you get 90-90, and all of a sudden you become very chesty, necky, your neck gets tight, your upper traps start to contract, you just start to get in this shrug position, and you're shallow breathing. Why is that, right? Is it stiff? Is it tight? Is it painful? Have you had a history of an injury? Right? These are things we have to take into account. Right? We have to understand, we have to create the awareness. And once we have that awareness, we figure out how to refine, how to make it better. Much like me working on this episode 2 of the podcast, it gets refined in time, but the only way it becomes refined is by honing the craft, by continuing to work on. So for me, at the end of the episode, I might say, oh God, that could have been better. But at the end of the day, what I am going to post this. 1000% I'm going to post this because you only get better in time, right? But you don't get better by deleting. You don't get better by self-critiquing yourself so hard that you self-sabotage yourself that you end up not moving forward, right? You become over analytical. Right? It's analysis paralysis, right? Another way people like to say it. So all this to say is whatever your craft you're working on, continue to work on it. Now I'm reeling it back in to the hips, right? So we got the seated 90-90 test. That's the first assessment. Second assessment, deep squat test, or even a squat test. I wouldn't even say a deep squat test. Can you squat? If you can squat, what does the quality of the squat look like? Right? If you can deep squat, what does the quality of your squat look like? Okay. We want to know, are your ankles stiff? Do you fall back because you don't have enough ankle dorsiflexion to get into a squat? Do your hips feel stiff that restrict you from going below parallel? Do you have a painful cracking in your knees that has been ongoing for the past couple of years and you just never had it checked out? Right? Um, do you have a pinching or a sort of a restriction in the hip that feels like you run into a wall? Like you go down to a squat and you just can't go any further because you have a hard stop, right? These are all different pathologies you want to take into consideration, right? So for the example of the ankle, your ankle doesn't have enough dorsiflexion. Now we're talking about ankle mobility, right? Your ankles are too rigid. They should be mobile structures. They are not mobile because they don't move right. They don't move efficiently. So now where is this compensated? I'm looking upstream at the knee, right? So that person who has very stiff ankles, I'm going to look at their knee and ask them about their knees and say, how are your knees feeling? Oh yeah, they just kind of they get a sharp pain every so often whenever I try to go in a deep squat. Oh, I wonder why. I wonder why you have that deep pain in your knee because your ankles don't. Right, this is the idea again. Right, the ankles are becoming stiff and stable, where now the knee becomes mobile where it shouldn't be stable. Right, so they're switching sort of classifications. So in the instance of the deep squat where you have knee pain, right? Sharp knee pain, it's been ongoing for a couple of years. You got good days, bad days, you manage it. Doesn't really swell up, but you feel the jab. Quick little jab, deep in the knee joint whenever you go into a deep squat. What am I thinking? Top of my mind, I'm thinking meniscus. Is there a meniscal lesion? Right? And quite honestly, I can't cite the statistic, but it's something along the lines of 40% of the people over the age of 55 have an asymptomatic meniscal lesion. And nearly every elite athlete that you see on TV, if you did an MRI of their knees, you would more than likely see meniscal lesions, right? But they're asymptomatic, right? So what does it matter if you're asymptomatic, right? Oh, I got a meniscal lesion, but I can do everything I love and it doesn't even matter. It doesn't have an effect on me. Now you tell me I have a meniscal lesion. Now we're going into the pain science, right? Now it's psychological. Oh gosh, I never felt anything in my knees, and now all of a sudden, doctors tell me I got a bunch of knee lesions, knee meniscal lesions, and man, my knees start hurting now, right? That's sort of like a placebo, right? It's not even a placebo though, because you're actually being dosed with the diagnosis of having a knee meniscal pathology, right? So at the end of the day, it comes down to how is your quality of life, right? So deep knee squat, deep knee flexion, sharp pain in the knee joint. It's been going on and off for a couple of years. You don't have any swelling, mild intermittent pain, especially when you go into deep squat. I'm thinking knee meniscus, right? Now moving on to the hip, you go into a squat, you feel a hard stop, right? You get to maybe like above parallel and you feel a hard stop. Somewhat painful in the hip, but feels like a hard structural stop. Now I'm thinking something like FAI, right? Femoral acetabular impingement or hip impingement, right? Is that a bony hard stop because you have too deep of a socket or you have too big of a ball joint, right? The hip is a ball and socket joint. Is one structure incongruent with another? And is that the reason why we have a hard stop? More often times than not, a hard stop when you go into a squat would be because you have too deep of a hip socket where it's essentially encroaching on the neck of the femur, right? So if that's the case, then you're not going to be able to go into as deep of a squat because the hip is essentially the hip socket is too deep for you to naturally articulate on, right? It's balance. It's all balance. So things to consider. Pulse piece. All right. Uh, let me wrap this up here because I'm just about to my destination. Next episode though. This next episode will be a full episode where I will be able to, excuse me, where I will be able to deep dive into the content because I will not be driving. But I will say that these driving podcasts is a motivational is definitely a motivational factor for me. One, because this is something I've wanted to started for a very long time, and I just never came around to because I was my own worst enemy, self-sabotaging, overanalyzing, and being overcritical. And this is just me surrendering to doing the work. Right. So this is kind of what it is. And I hope that this provides some inspiration, and I hope the information in this episode was useful. But before I close out, I have one more test, one more self-assessment, and then we'll close out. The last self-assessment here is going to be a half kneeling hip flexor stretch. So can you get into a half kneeling position? And that essentially looks like if you were about to lunge and you just go all the way down and you get that back knee on the ground, that is a half kneeling position. Can you get in that position? And if you get in that position, do your hips feel tight? Do you feel a stretch on the front side of your hip? Do you twist? Do you rotate? Right? If you do, you might have some stiff hips. Well, I guess, and then on the contrary, that's the front side of the hips, not on the contrary, but that's the front side of your hips. You can also go onto your back and do what's known as a straight leg raise, right? So how high can you raise your leg? And when you raise your leg up, do you feel tightness? Do you feel tension? If you do, where is it? Is it on the hamstring? Is it on the backside? Do you feel like a jab on the front side of the hip? Do you feel clicking on the front side of the hip, shifting anywhere? These are things we want to build awareness of. So we got the pigeon pose or the side seated 90-90 stretch. We have the deep squat or even just a squat test. And then we have the half kneeling hip flexor and supine hamstring or a supine straight leg test. These are great self-assessments to create awareness around how you're feeling, around the quality of your movements, right? And to better check in with what you need to be addressing. Is it mobility? Is it stability? Mobility? Is it stability? What is the thing that we're lacking? And how can we nurture that? Right. And by creating that awareness, you create your own micro strategy, right? Micro break strategy. Remember, like I said, the mantra is the 1-2 method. So you create your own micro strategy, right? Micro break strategy. Remember, like I said, the mantra is the 1-2 method. So every 1 to 2 minutes, every 1 to 2 hours, you're getting 1 to 2 minutes of meaningful movement, right? So you do this self-assessment, you do the pigeon pose, and you're like, oh man, my hips feel real tight, right? You do the deep squat test and you're like, ooh, my ankles feel a little stiff, right? And then you do the supine straight leg raise and you're like, ooh, my hamstrings feel a little tight. And then you do the half kneeling test and you're like, ooh, the front side of my hips don't feel right, but they're still a little stiff. You just created your own stretch routine and plan, right? You got to work on the hamstrings, you got to work on the front hips, right? You got to work your quads, right? And then you got to work on your glutes. These are structures that you can work on. And then you do 10 reps of each of whatever that thing is that you're going to work on. You can YouTube the stretches, right? But what you can't do is have an understanding of the principles of how you self-assess, right? So do that self-assessment, figure out where your needs are, meet yourself where you're at, and work on it. And incrementally in time, you'll make that progress. But all this to say is make sure you're taking care of yourself. This episode today, again, was just talking about the hips. We've talked about mobility. We've talked about stability, understanding the hip spine connection, why that's important, why your hips are tight, as well as a quick little self-assessment. But I just want to thank you for joining. If you listened to this episode all the way through, again, thanks again. If you want to follow me, I'm on TikTok. I'm on Instagram at sheldon.mbt. You can also join my free school community, school.com. That's SKOOL.com .MBT. You can also join my free school community, school.com. That's SKOOL.com movement based. You can join my free group where I post podcast episodes as well as provide any insights, writings, and it's a nice little community for everyone to get involved and have conversation in. So again, if you've joined me, if you've listened to this podcast, I can't thank you enough. I will have more episodes as well. And I encourage you all to tune in, to give me a like, to give a follow, provide some feedback on this episode as it helps me refine future episodes and give me some strategies to work on. And I just want to say thanks again. And if you have any questions, if there's something that you had on your mind that you wanted to talk about, feel free to either leave a comment, shoot me a DM, or you can email me at Sheldon at sheldonmbt.com. I promise I'll get back to you. But yeah, thanks again for tuning in, and I'll see you all in the next episode.